Thank you, Dr. Harlan. And it's really hard to follow a talk by Dr. Albin, so I'll do my best. Thanks for attending today. And I really want to focus on the implementation side. I think that all the inspiration that you probably gained from listening to Jacqueline's talk, I really have tried to challenge that over the, or channel that over the last several years to how do we take this inspiration, this passion project, as she talked about, and channel it into the work that can be done to create a financially sustainable model for culinary and lifestyle medicine. I'm embarrassed to admit that I just learned that there's actually something called implementation science. And I would ask all of you, as one of your takeaways, to think about what you're learning in terms of culinary medicine and lifestyle medicine, and how can you really spur on that implementation science within your organization and channel all of this passion and energy that you have toward this work in caring for our patients in a different way and building a model that does become sustainable within healthcare organizations. I'm at Spectrum Health in West Michigan, and we're an integrated health system. So what that means is that we have an integrated payer arm within our organization. And it has many benefits in terms of getting financial incentives to align. And that's what a lot of this work really requires. So as you think about what Dr. Albin mentioned in terms of the steps that she asked you to consider as you're moving your projects along, also try to determine where are those incentives aligned financially. And to the point around understanding your organization's mission, vision, and values. I think throughout our journey over the last 6 to 7 years, we've always fallen back on our organization's mission to improve health, inspire hope, and save lives. And every time I think about that mission, I'm like, that's culinary medicine, that's lifestyle medicine. We can answer that equation on every level. So I would encourage you, how do you align the work that you're doing to what the organization overall is trying to achieve? I do have a disclosure to report as a paid consultant for Diet ID. And here's what I'd like to walk through with each of you. So I'm going to get a little bit more granular, I would say, in terms of thinking about the billable environment. So if you're currently in a health system that operates out of a fee-for-service model, many organizations are there. There's growing recognition to the value of population health, that care transformation, accountable care organizations. That's where a lot of the innovation around building financial sustainability for preventive services is happening. But while we're still very much sitting in a fee-for-service model, shared medical appointments can really be a starting point in addition to e-consults and remote patient monitoring. These are some of the billable encounters that we can begin to implement as culinary and lifestyle medicine specialists that will allow us to achieve reimbursement and sustainability. So we'll talk briefly about what the definition of shared medical appointments are. What are some drawbacks and considerations when you're thinking about implementing shared visits, and who in the crowd is already using shared medical appointments? I know Dr. Helen at Mass General, there's a few other hands. Great. Yeah, so this is not a new visit structure, but rather something I think we can leverage as culinary medicine specialists much, much more. We'll talk about that recipe for success, things to think about, and I hope that's sort of the section of takeaways that you might be able to take some of the learnings from the afternoon talking about clinical practice transformation and really put those into practice when you go back to your organizations. We'll touch on briefly the billing and coding, but I would say this is the piece that's probably the most straightforward as long as you align the conversations with the right individuals. And then finally, we'll look at our model at Spectrum Health, what we've implemented, one of our longitudinal programs called Cooking for Health, which is a culinary medicine program through and through. So with that, as I was preparing for this talk, I went back years and years. I'm like, when was that first visit to Tulane at the Goldring Center for Culinary Medicine, and here with Carrie and Chef Leah, both chefs, of course. And I was just reminiscing about this opportunity to learn alongside of them. That's where I had originally done my courses for the CCMS and that certification process. And it was just a wonderful experience. And it reminded me that every moment in time is just the seed of change. So when we have one of these inspiring ideas, if we're ready to make a change in our career, if we're ready to take that step forward and change something within our organization, it just takes that seed of knowledge and inspiration, and then from there really fostering it so it can grow. This is how we talk about culinary medicine and lifestyle medicine within our organization at Spectrum Health. We've divided it into what we call the pillars of lifestyle medicine. This is, terminology from the American College of Lifestyle Medicine as well, but we've refined these into the 4 pillars, with Nourish really representing our culinary medicine arm of the program. So let's talk briefly about what a shared medical appointment is, and it's quite simple. So again, if you want the elevator pitch around what a shared medical appointment is, it's a clinical encounter with a healthcare professional with a group of patients. That's it. It's really straightforward. It's been implemented, I would say, probably for decades now, mostly within the primary care space, but I've even read literature in urology around pre and postoperative care. So there's lots of different models that exist within the specialty realm as well as primary care, where shared visits have been a model of care for a long time. Lots of patient education can occur. Physical exam, a lot of that can even be a visual exam. For the clinicians in the room, much of what we do is visual-based diagnosis. What is their overall, behavior, their gait? Is there any respiratory effort? We can document a lot of our clinical encounter physical exam by really just doing that visual-based assessment. Of course, if there's a need for additional physical exam, that can be offered to the patient, but it's not typically required for the purposes of the billing and coding piece of this type of visit. It's certainly an effective way that you can spend more time both with the patient and the patient with the provider and that team-based care. We oftentimes will have either a chef or a health coach, and we'll talk about the structure of that team, but it's an opportunity for patients to really have a deep dive, to work alongside of other patients, of course, and then be able to really spend time with the expertise within the team, not just the physician on the team. Patients always learn from each other. And I think this is always the most inspiring part of a shared medical visit, is the wisdom within the group and leveraging that conversation, asking questions that allow patients to answer for one another and really talk about the skills and that self-efficacy part that we really need to encourage and allow patients to build as they learn about new cooking techniques or build their nutrition knowledge or talking about physical activity. All of these pieces really is how do they apply it to their own lives? And oftentimes it's in conversation with other patients in the visit where those tips and skills are shared the most. And then of course you can take these visit structures and have them occur over a period of time, so you can have more of that longitudinal follow-up and move that education, that skill building along as you work with a group of patients. So why are we interested in shared medical appointments? I already mentioned the reimbursement structure is there, so we don't need to make that up. So we talked earlier, Dr. Albin talked about what is that path that's already paved. This one is here. It's a typical billable encounter that already exists. You're not creating anything by using this encounter. Within that lifestyle medicine and culinary medicine environment, we're getting at the root cause of what drives disease. We talked about how the wisdom of the group can really create that more effective care model and that self-efficacy building. And there's a reference at the bottom there. If you're looking for references, if you're creating your proposal for shared medical appointments, I would encourage you to look up some of these references so you can use them when you're talking to your C-suite or your executive leaders. So some of the benefits from the side of the clinical team. Of course, we can work with a group of patients. How often do you say, wow, I said the same thing 10 times to 10 different patients? Wouldn't that be amazing if I could say it one time to a group of 10 patients, right? And then to have shared conversation around that topic. So that's what can happen in a shared medical appointment. Productivity has been demonstrated time and time again when you have max packed groups. So that's one thing I would encourage you. If you're looking to build a shared medical appointment model, is determine what is the reimbursement, the financial model by which you need to achieve to make it a sustainable model for you. And then you'll really need to recruit patients to really encourage them to come into that visit structure and rally your entire team around how to speak about shared medical appointments and get patients excited about the experience. Visit capacity can certainly be expanded. We discovered that in our own lifestyle medicine clinic. Fortunately, we're at a place right now where we have exceeded capacity. We get about 50 to 90 referrals per week from our primary care teams, from some of our specialists as well. And we have exceeded capacity at this point, and we're booking out 2 months from now, which is something we always dreamed and hoped for, but now we're struggling with how do we meet the demand of what patients want and need today, not 8 weeks from now. So utilizing shared medical appointments is a great way, even for a new patient appointment. And we run those every Monday morning. We have new patient shared medical appointments, and it's really expanded capacity for our group. And then, of course, the education we talked about. For the patient, again, we talked about more time with the patient, other patients with that extended team, and the group support around health behavior change is so critical. We talk about it as changing in community. So we know that people want to hear that they're not alone in their struggles to make changes. And it's validated time and time again when they're sitting alongside of other patients who say, yeah, I had that problem too, and this is how I solved it. And it's oftentimes much more effective hearing it from another patient. Some of the potential drawbacks, and I would say definitely potential, is the time required to plan these visits is something that's going to probably take at least 10 to 12 weeks. So that's one thing I would share with you. And I have a little bit of a timeline that you could work through to get you to the launch of your first shared medical appointment. If your visits aren't full, you will lose productivity because you've scheduled typically a longer amount of time, anywhere from 60 to 120 minutes, depending on the type of visit that you're looking to deliver. And if you're not max packing those visit encounters, you will lose productivity, and that becomes quite challenging. I've discovered with our scheduling team that as you template longitudinal programs, it gets really complicated within the electronic health record. So you need to, really have good conversations with your operations team so they understand what we're trying to build towards, so everybody has that shared vision that we're working towards. For the patient, occasionally we come across where patients don't feel entirely comfortable sharing their personal health information. But I have to admit that's been very infrequent, and we typically uncover that before patients are even entering into a shared visit, and then we'll just book them as a one-on-one visit. So always having that opportunity so patients can decide what they think might work best for them. And then, of course, the visits are longer typically, so patients may have, struggles really attending those visits because they're having to block out their work or their childcare or things like that. So let's get to sort of the nuts and bolts of planning for your shared medical appointments. A couple of references. This was like my Bible for understanding how to run a shared medical appointment. Ed Nossinger, he has written about this extensively. This actually, I think if you look for this book on Amazon, it's quite expensive, but there's a smaller version that I think gives just as much information. I should have really included that photo. But Ed Nossinger, look for his books, get one of them, get ready to highlight everything in the book so that you can use that as you're building your knowledge and skill to really implement shared visits within your clinic model. Write in SBAR. Who's written in SBAR before? Does anyone know what that is? Okay, a couple hands. All right. So I have certainly discovered I've had kind of my health administration or business administration, I feel like, feet to the fire for the last probably 5 years or so, and learning the terminology. As you're building your programs, get familiar with some of the business language because it's going to help you along the way. So an SBAR is, and it's an acronym, so situation, background, assessment, and recommendation. And it's usually about a 1 to 2 page document, but I have found anytime I have an idea that I want to move forward, I write an SBAR. I used to kind of drag my feet a little bit. I didn't want to write it. I didn't want to, take everything that was in my head and put it down on paper. But I have found when you can deliver this document to your executive leader and say, this is my recommendation. Oftentimes I'll give 2 options. I always list the option that I think is better up top, and really drive them towards that as best I can. But you'll find that this will get you much further along the way when you start to generate these SBARs as you're coming up with implementation ideas. I can't express enough the importance of connecting with your rev cycle team. So if you don't know who they are, find out who they are and become friends with them. Invite them to a culinary medicine class and get to know them, befriend them. So they're going to be the team that's going to look at your visit type structure. They're going to look at the payer models, and they're going to figure out where the problems are. And then your compliance team is going to weigh in. Legal is going to be there. So all these people need to be involved if shared medical appointments don't currently exist within your health system. So get connected with them early on and start the dialogue so that they can be supportive. And truly, if you paint the picture for them of what you're trying to create, I have found they've almost become my greatest allies in some of this work. They understand, they get inspired by hearing about it, and they really want to see this work become successful. Similarly, connect with your IS teams. So if you're thinking about virtual shared medical appointments, do you even have a platform that's HIPAA compliant that your organization will allow you to use for your shared medical appointments virtually? I think now that is probably less of a concern given COVID and everything we've learned within the virtual environment, but it is something to consider and make sure you're thinking about well in advance. Your legal team, I mentioned, when you think about the consent forms, is there a consent form? And I'll show you an example of what we use at our hospital system. Is there a consent form that talks about shared medical appointments? If not, that needs to be drafted, and you're going to need your legal team to put their legalese and make sure that it works well within the other general consent forms. And then from there, you need to take yourself on a roadshow. That's what we always called it. Here's the roadshow. Who are we going to talk to? Which organization? Which service line? Who do we really want to engage with? And which problem can we solve for them? I can't stress enough what Dr. Albin said earlier about how do you solve other people's problems? And I think that's what we're in the business of when we're trying to create the sustainable model for culinary and lifestyle medicine. What our focus is at Spectrum Health is how do we help our organization win within population health and risk-based contracts. So if you know that there are full risk contracts in place within your organization, you are going to be part of solving their problem because we need disease reduction and mitigation strategies, and culinary and lifestyle interventions can certainly achieve that. So here's your 10-week timeline. I hope you find this helpful, but it's something that I took a little bit from Ed Nofsinger's books, but it's been quite true to our experience in implementation at Spectrum Health. So when you're thinking about, if you're going to launch September 1st, kind of walk back from there and how can you achieve all of these steps to be ready to go on September 1st? So your visit structure, is it going to be a single visit? Is it going to be a series of visits? And what is the content that you're going to use? Do you need to get that content through patient education? Do they need to put their stamp of approval on it? We know that takes oftentimes a couple months. So start creating that project plan and walking it out to 10 to 12 weeks. You need your roles and responsibilities within your own team. So it's really important, again, within your own team, to get them excited about what's being built and for them to really understand what their role will be within the visit structure. Then everybody starts to build confidence, all that nervous energy that your team might have thinking about this. I've found that just good role description allows everyone to feel like they're an important piece of the visit. The marketing and communication plan, incredibly important. So whether you have the opportunity to post this on a website, how are you going to describe what a shared medical appointment is? Why would someone be interested in attending that versus a one-on-one visit? So really, again, paint that picture in a way that your prospective patients might be excited about that process. And then, of course, how do you communicate it to referring providers? Do you need to build a slide deck where you're going to talk about the services that you provide or some of the outcomes that could be achieved? Do you have stories that you can share of patients that have gone through your programs? In the beginning, set up what is going to be your data plan, your documentation, and then of course the billing structure. The billing you're going to be walking through with your rev cycle teams and your billing and compliance teams. The documentation is typically going to look like, what is the smart phrase that you're going to generate to utilize within that shared visit structure? And then finally, again, another really critical step, if this is a new process, is schedule a live run through with your team. No patients there, but everybody walks through the process of what their role is, and have that workflow document so everybody, again, feels confident. Every team member feels confident going through the process. So here's what it looks like for our culinary medicine team. We have a chef. I oftentimes will use the chef and lead facilitator as an interchangeable team member within this visit structure. And what is the role of the chef? Of course, they're going to be doing the culinary demos. Are they going to be doing a demo or cooking with the patients? Are the patients going to be in person? Are they going to be virtual? If they're cooking along with the chef, they need an ingredient list. So these are all sort of the downstream things you need to think about when you're considering your visit structure. Do you have a documenter? So we've been fortunate, given the excitement and interest in culinary and lifestyle medicine, we have found fabulous interns who want to work on our team. And they're often graduates, or they're, getting ready to apply to medical school, or, different career paths where they're interested in learning more about the work that we do. So we've, along the way, had several that have become just exceptional individuals on our team in supportive roles. So they often will document within the shared medical appointment structure. We don't call them scribes. Apparently that's like a dirty word in our environment, our health system. I'm not sure why. So they're the documenter. And then of course you have your physician or your APP, your medical assistant, who's usually checking patients in, getting any vitals that might be necessary. And then the PSR is a critical patient service representative. You may have a different term for that front desk person who really needs to be able to talk about what the visit structure is, and to set up that communication strategy with patients, before the program, before the visit, and then as they move through programs. So when you're preparing your patients, if your particular program, and we were, just a little bit about billing and coding, you're going to find that you'll have the most success if you identify criteria for individuals that should be in, for example, a longitudinal program. So more than one shared medical appointment. Oftentimes we're screening for patients who have obesity plus at least one other metabolic risk factor. And those are the individuals that need that more intensive longitudinal program. And they'll get referred into, for example, our Cooking for Health program. So the PSR from there is going to schedule the visits. It's all going to be templated. We have 3 different physicians on our team. So dependent upon who will be leading that series of visits. And we typically try to have the same physician, take a cohort through the entire experience. There oftentimes will be, verbalized expectations. within the context of the group and trying to attend all of the visits rather than, more haphazard. So we'll really try to talk to patients ahead of time. Does this seem like something that they can build into their own personal schedule? If not, maybe this longitudinal program may not be the best fit for them. We have data collection that occurs prior to the onset of, or at the beginning really, of all of our new patient encounters. So when you're thinking about culinary medicine, diet quality assessment and having that listed as a discrete value within the electronic health record to prove the value of diet quality improvement as patients move along in programs. I cannot highlight this enough. I think when we think about the financial ROI and for population health, that return on investment, diet quality change and improvement as a leading metric and being able to measure that reproducibly over time is going to be something collectively we all need to be thinking about together to prove the case and the value of culinary medicine. So that's what happens as patients enter into programs. If it's virtual, we need to set them up with all the links, of course, and then we do reminder calls for all of our patients. For the Cooking for Health series, we'll typically mail a binder home that has all the recipes, ingredient lists, all the patient handouts that we use in the context of that visit. So they have a packet that they can, refer to as they're going through the program, whether it's in person or virtual with us. Visit types, this is within EPIC. That's not so important, but really to highlight that if the visit type doesn't exist, it needs to. Before you can start delivering shared medical appointments within an electronic health record, the visit type structure needs to be there. So these are all just little pieces that need to be in place when you think about that project plan. Every one of those steps needs to happen. None of the individual steps are particularly complicated. It's just there's a lot of them as you lead up to delivery of shared medical appointments. So you'll want to name it something along the lines of group visit, shared medical appointment. You'll decide within your organization what the right terminology is, and then you'll want to use it consistently. So most of our shared medical appointments are billed as a 99213, occasionally 99212, but it's typically 99213. So you'll get your history and exam. Again, most of it is a visual-based exam. I do not take patients out individually to do individual private exams unless there is an individual need. That's always available to our patients, but I have rarely, I want to say never, have been asked for an individual exam within the context of these visits. So that really shouldn't be a barrier that you'll need to overcome. The problem-based charting is something that I would recommend pursuing if you're not currently doing that already. So within the context of a patient's problem list, as you're identifying all of the metabolic risks that you are intervening upon with your culinary and lifestyle interventions, you can be documenting those within that problem-based charting. And then, of course, if you're reviewing data, most of us are looking at cholesterol, we're looking at hemoglobin A1C, prior blood pressures. So we're doing that data review. You're often reviewing other providers' notes, understanding the patient a little bit better before they enter into the visit, and just documenting that you have done that data review before you've seen the patient. And if you have a documenter, that's where the attestation comes into play, and just a brief note to that. Here's just a quick example. This is from our Cooking for Health shared medical appointment. And again, it's just, this is how we capture our HPI. And it's often in the context of a slide that we'll have visible to patients that have one or two questions. And we ask them each individually to comment, if they're willing, on, what is it that brought them to the visit? What changes are they noting? Are they seeing their blood pressure, their A1C improving? What questions or challenges do they have? And then we document that as the HPI. And like Jacqueline had mentioned, she has not seen any problems with reimbursement, nor have I, with the structure that we've created in our shared medical appointments. These will be in the slides that you can view later. This is what it looks like for our problem list documentation. We're talking about calorie density principles, and when we're looking at weight management, For cholesterol reduction, we're talking about the link to saturated fat and how do we build in healthier fats into the diet. Under where it says problem list and data, that's where we're looking at that diet quality change. And as a patient is moving through a program, we're documenting how is diet quality changing related to the intervention that they're involved with. And then at a certain point, we'll be at a time frame by which we would repeat labs as that intermediate marker of how their biomarkers are improving as a result of the intervention. We do body composition analysis as well. So if you're able to do that in your clinic, I find that that's a really great opportunity to engage individuals on their own, understanding their health on another level, rather than just that one number on the scale. If we can look at percent body fat, skeletal muscle mass, and how do we intervene with lifestyle and culinary interventions to improve on our body composition. We'll often have a visit summary, again, created as a smart phrase so we can drop those in quickly. We're not having to recreate these every single time we run a shared visit. If we're talking about, carbohydrates in the diet, we might, drop a visit note that addresses that. So we have a whole series of cooking for health, shared medical appointment, smart phrases, and we can select from those so we can quickly add them into that visit note under the HPI portion. This speaks to when we have a chef-led facilitator and we're actually cooking with our patients, we'll drop that into the visit note. So we have documentation of what actually occurred within the context of the visit. And I've actually had our billers and coders say, like, your notes are the most interesting to read. I love, and I think they just really enjoy seeing how health is being addressed through culinary medicine. All right, so a little bit about what we're doing at Spectrum Health. And here is our teaching kitchen. Yes, we have much gratitude to be able to really work and see patients in this space. So we have 6 stations with a cook station up at the front where our lead chef can be situated. We have a library, so patients, we're oftentimes prescribing books to our patients. We have a little library, just like back in the day when you sign your name in the library card, that's what we do with our books here. And then further in the back where you see that frosted glass is our individual patient exam room. So we'll see patients in there one-on-one, we'll do telemedicine visits from there, but then in the large classroom space where the teaching kitchen is, and actually adjacent to that as well, there's a larger classroom space. So we'll oftentimes move from the classroom into the teaching kitchen, back into the classroom. So we really flex the space quite a bit. And we have some video equipment that I think it's in a slide coming up. So we've set up this space to be, as I mentioned, very flexible. If we need to be doing more virtual work for that day, we get all the camera equipment up with the good lighting and get that all going. Otherwise, we're going to put that in the back closet and we're going to, leave these spaces open so our patients can comfortably work around these cooktops. And we were not funded to build this space. So I just wanted to make that clear. When you're looking at this, it looks beautiful and amazing. And we happened to come across the space. It already existed. It was actually built as a children's kitchen in a space called the Downtown Market. So on the first level of the Downtown Market, there's small vendors that sell different items. And then as you go upstairs under the second floor, you have the teaching kitchen space, which now does say Spectrum Health Medical Group. And as we were looking to build our lifestyle medicine practice, we actually originally were going to co-locate with our preventive cardiologists. And for a lot of technical reasons, it didn't quite work out to locate in their space. So we began to ask our real estate people within the organization, why can't the teaching kitchen be labeled as medical group space? And he said, well, I'm not really sure about that. And we said, can we invite you into the space to do a walkthrough? And so he brought his team. This is about 3 or 4 years ago now. And they walked through and, so we said, well, what do you think? Can this happen? And he's like, I can't think of a single reason why this can't be medical group space. And the reason that that's important, again, this is going to be another potential partner or ally that you need to find out who they are, how to have them, visit your space, because they make those real estate decisions for the organization. So we rented the space. We had been working out of it for several years with a grant funded program. But then once they labeled it as medical group space, that's where the billing mechanism through insurance could begin to occur. And that's why that's important. We do this both virtually, in person, we do it hybrid. So sometimes we'll have half of our patients in, the other half are on a big screen virtually. So think about that flexibility so that you can, again, max pack your visits. You do not need to have a teaching kitchen. You can have a demo cart with some good lighting and good, decent audio so that you could do, and doing it from a medical group space. I guess that's the other thing is you need to understand where can you situate your demo cart, for example, if you're going to deliver a shared medical appointment and have that be a billable encounter. Up front is one of our amazing registered dietitians who's leading a group of patients here. So finally, the Cooking for Health shared medical appointment series. It's, as I mentioned, designed for individuals who have obesity and other chronic disease. Over the course of 6 months, they are involved with 4 shared medical appointments and then 3 months of group medical nutrition therapy. So that group of patients stays together for the total of 6 months. And for half of that time, they're working with chef and physician, and the other half of the time, they're working with a registered dietitian. And those are all reimbursable, billable encounters. And of course, they're improving their diet quality through the appointments. The consent for shared medical appointments, if this is something that you might need assistance with, you can reach out to me, but it just needs to be in place so that patients understand what they're consenting for, that they're joining a group visit. And we talk about that when patients enter into a shared medical appointment, whether it's in person or virtual, we just share this little confidentiality statement so that it's there to be read and visualized. And I'm sure each of you would have a similar statement that you could just draw attention to make sure that whatever is shared within the group stays within the group. One thing that we have encountered is many family members would like to attend the visit with the patient. And that has been a challenge, especially recently. Whether they're there for support with transportation or lots of other reasons that we would want a support person with a patient, that has been a barrier where we can't allow family members to be in attendance in the shared appointments. I would say that's one potential big drawback of the shared appointment model. When we start a visit, we usually orient everyone around what's going to happen in the visit. Again, I think it gets people like on the same page together. We want to have those group introductions. We want to have them answer a couple questions or be thinking about a couple questions. And then, what are we going to do otherwise? Are we going to do some chef skills? Are we going to, work with our chef and cook together? And then after we make food, we typically then sit down together, and as the patients are able to enjoy the food that they've made, we're wrapping up, we're goal setting, we're talking about the implications and answering questions about what they've just made and getting ready for the next visit. So as I sort of finish the medical portion of the visit, chef will often then come back on and talk about and preview what comes in a couple weeks from then. Oftentimes, if we're cooking with lentils, for example, we'll talk about where to find lentils, what are the different types, so they can be prepared for those visits. So it's, I think I've said all these things, except I guess the thing that I haven't mentioned is when we're doing the visits is that we want to be looking at the data, both at the beginning of the visit, the midpoint, and the end. So when we're proving out that return on investment, that disease mitigation or reduction, we actually have data that we can point to and trend throughout these patient experience. Then to be connecting that with total cost of care reduction. We might find that we have reduced ED utilization, we have reduced hospital readmission, we have reduced pharmacy spend. So we're tracking all of these items because these are big ticket financial items for healthcare organizations that are trying to figure out how to reduce their risk, their financial risk with that total cost of care. And then of course, the patient experience. Here's what happens in our visit. I know you met Chef Elizabeth the other day. So when we're doing it virtually, these visits virtually, Chef will often be in this part of the teaching kitchen. We'll often then have the physician in the exam room. We've done it lots of different ways, but in terms of visit flow, we have found that this typically works the best. So we can have both of those providers in the visit with that group of patients. And certainly during the time, and this is something that you might want to consider, during the time that Chef is cooking with patients when they are virtual and even in person, you could be doing e-consult. You could potentially have a follow-up visit as well. So there's other ways to continue to increase practice efficiencies. And as we look at that sustainability model, some of our diet quality improvements that we've seen through the program are pretty significant. So if we look at sodium reduction, we look at that increase in fiber, this is what we're trending. So again, I talked about that discrete value of what we can follow over time. We measure it in a flow sheet within the EPIC EHR. We measure the healthy eating index change. So it's that level of change from 1 to 100. And as diet quality is improving, we're often able to look at some of these specific nutrient profiles, but we can see the healthy eating index improving over time, which will correlate with reduced, all-cause mortality, reduced ED utilization, all of the, reduction in hemoglobin A1C and blood pressure. Here's the patient experience feedback. And I would encourage you as you're building your programs to really ask patients to talk about their experience, what could be better. And I think we've been in a constant process improvement phase for years now. So we're always looking to better the program, bring in different recipes, deliver it slightly differently. So I'm not sure when that process will be done, if ever, but that patient experience piece is incredibly important. So finally, the takeaways for building your shared medical appointment model: build the relationships with the teams that you need to interact with. So we talked about rev cycle, billing, compliance, legal, maybe real estate. All of these individuals will be critically important as you're evaluating whether or not you can build your shared medical appointment model. Paint the picture for these individuals so that they can really rally and get excited about what you're looking to build. We talked about aligning with organization, mission, vision, and values. So when you speak to your executive leadership and reinforce how you're helping to achieve what they're looking to achieve, it just builds support for the programs that you're implementing. Measure meaningful metrics. So we talked about diet quality. We talked about some of those intermediate metrics, those biomarker changes, whether it's weight, blood pressure, A1C. All of these become the story that you tell with your patients and the results that you can achieve, the patient experience. Some of our programs have a net promoter score of 100, which is unheard of within healthcare. So there's a real opportunity to tell a fantastic story within your organization. And then of course, committing to that continuous process of making it better for your team, for your patients, for the healthcare organization as a whole. And if you'd like to join any of our culinary medicine classes, you can find how to register for those. We have a Facebook group. I know we didn't talk a whole lot about social media, but we have a very active Lifestyle Medicine at Spectrum Health Facebook group. It's a closed group. Anyone is welcome to join though. We'll let you in, of course. And I think we have about 5,000 members that are quite active. So we post recipes, we talk about upcoming classes, individuals will share their own feedback and some of the dramatic health improvements that they've achieved. So it's a wonderful place to share that experience. And of course, connect with me on LinkedIn if you'd like to learn more, or even come to visit our Teaching Kitchen site. I know several of you have asked to do that, and we'd welcome that. So thank you very much.